Well, hello once again, everybody. My name is Kwa, lecturer of anatomy, physiology, and medical terminology. And today we will be once again diving into the abdomen to discuss something that I find very, very interesting, the peritoneum. So in today's lesson, we will go through the abdominal cavity, as well as the peritoneum, the membrane that lines the abdominal cavity and form a cavity of its own within the abdominal cavity, the peritoneal cavity. Then we'll discuss the components of the abdominal peritoneum as well as the pelvic peritoneum. And we'll actually skip over most of the development of the abdominal viscera because you guys will probably learn it in embryology anyway. We will just remind you guys some of the more important points about the rotation of the foregut, midgut, and hindgut. All right, so first off, let's go into the abdominal cavity. The abdominal cavity is a very, very big cavity that extends all the way from the superior diaphragm all the way down into the pelvic inlet. All right. And the general orientation of the abdominal cavity is a central gut tube. All right. A central gut tube, the gastrointestinal tract right here. All right. That was supplied by branches of the aorta. Now, the gut tube is actually divided into three: the foregut, midgut, and hindgut, and each one of them receives a branch of the aorta. All right. The foregut is going to receive the celiac trunk. Okay. The midgut is going to receive the superior mesenteric artery, and the hindgut is going to receive the inferior mesenteric artery. And therefore, in an adult orientation, you will find that those three arteries are going to be the arteries that supply the component of the foregut, midgut, and hindgut, respectively. All right. Now, the gut tube, also called the gastrointestinal tract, also is hung from the anterior abdominal wall or the posterior abdominal wall by thin sheets of tissues called mesentery. In embryology, there are two sets of mesentery: a ventral or anterior mesentery for proximal regions of the gut tube, and these will become, number one, the falciform ligament of the liver, and number two, the lesser omentum. And then it is also going to be suspended or hung by a dorsal posterior mesentery along the entire length of the system, and you will see the remnant of this posterior mesentery all the way through the gut tube. All right. Now, parts of the mesenteries are named based on the organs they suspend with or with which they are associated. Like, for example, you got the transverse mesocolon that is associated with transverse colon, or the sigmoid mesocolon that is basically suspends the sigmoid colon. Now, the organs such as the kidney that are not suspended are associated with the abdominal wall. Now, the kidneys and some other organs are what is known as retroperitoneal. Okay. And retroperitoneal organs are basically behind, they stay behind the peritoneum, basically. And we will discuss them following here. Okay. So now let's go ahead and discuss the peritoneum. So the abdominal cavity is lined by this membrane, the peritoneum. So if you look at a picture on your right, it is a sagittal section of the abdomen. And you can see right here, this membrane in white here that extends all the way from here, okay, covering the liver in its parts like this, forming these omenta right here, and extend all the way to go down like this to cover up the superior portions of the pelvic organs. That is going to be the peritoneum. Now, the peritoneum is going to fold, okay, in order to create a type of peritoneum that lines the wall. Like, for example, this peritoneum is lining the abdominal wall. You call that the parietal peritoneum. Okay, remember when we talk about the parietal and visceral pleura, as well as the parietal and visceral pericardium. All right, so this is the same thing. Okay, so even though it seems like the parietal and visceral membranes are two different layers, they're actually just one layer. Okay, they fold back on themselves. Okay, the parietal peritoneum, as it goes to a viscera, like for example, this liver right here, is going to fold back on itself. And parietal peritoneum at this moment is going to change into the visceral peritoneum that is on top of the organ. Okay, now this cavity right here, the cavity that is shown here in gray, is what is known as the peritoneal cavity. And it is a little bit different than the abdominal cavity. All right. So now remember what we said about the abdominal cavity. The abdominal cavity extends all the way from the diaphragm up top onto the pelvic inlet down here. So now you can think of the pelvic inlet as being around this area here, right? Because the anterior part of the pelvic inlet is the pubic symphysis, that is right here. And the posterior part is the promontory of the sacrum, which is basically right here. So basically, the abdominal cavity will extend all the way from up here to down here. Okay, so that's abdominal cavity. But then again, the peritoneal cavity is going to go down here a little bit, and then it just ends down here. Okay, so this is the boundary of the peritoneal cavity, right? So that is the cavity that's going to extend up here like that, but not quite as much superiorly as the abdominal cavity. So you can think of the peritoneal cavity as another cavity within the abdominal cavity. Now I just realized that if I get the cavities all in red like this, it's harder to see. So how about this? Okay, this is the pelvic inlet here, and that's where the abdominal cavity ends. Okay, now let's go ahead and draw out the peritoneal cavity in green. So the peritoneal cavity is going to be this cavity here. That is within the abdominal cavity. You see that? Okay, and this extend. Let me just skip all of this. Okay, and just go ahead and just lines this like this. See that? Okay, so that cavity right there that I'm drawing, that right there is the peritoneal cavity. So you can think of the peritoneal cavity as being within the abdominal cavity. All right. So now we talked about the parietal peritoneum as the part of the peritoneum like this that lines the abdominal wall. And then when the parietal peritoneum go up here, it reflects onto organs to form what is known as visceral peritoneum. So every single part of the peritoneum that is right here, right here, right here, that's on top of organs like the intestine right here, they are all visceral peritoneum. Okay, and everything such as this or this is going to be parietal peritoneum. Make sense? All right, so now normally abdominal organs will completely fill the abdominal cavity. Okay, normally there would be no space in between the stomach here and the large intestine here, as well as no space between the stomach and the liver, and the stomach and the duodenum and the small intestine with, like, you know, other parts that we have just said. And therefore, even though in this image you can see the peritoneal cavity as being this huge cavity right here in the abdomen, it's actually only a potential space. And what that means is usually there would not be a space here. Every organ has already filled the space. All right. But should there be some kind of fluid or some kind of object that is in the peritoneal cavity, then the membranes or the structures within the abdomen, like the intestine, is going to be pushed away and revealing the peritoneal cavity. All right. So a potential space will not appear unless you got something abnormal going on within that space. Like, for example, the accumulation of fluid, then it will appear. All right. Okay. So now let's go ahead and see the similarities, okay? The similarities between what we've known about the lungs and heart and the peritoneum, okay? So now let's just go ahead and draw our lung here, okay? Let me draw out the right lung just for the illustration purpose. And I'm just going to use the blue pen in order to draw out the visceral peritoneum. Visceral pleura right here, okay? The visceral pleura is going to be right on top of the lung like this until you get to the hilum, right? And it's just going to cover the top of the lung, okay, until you get to the hilum. When you are at the hilum, that visceral pleura is going to reflect upon itself to form this red layer here, the parietal pleura, okay, which will continue to run outside of the visceral pleura and attach itself to various structures on the chest wall, all right? And this cavity right here, in between, this cavity by yellow there, that would be the pleural cavity or the pleural space. Okay, so now a similar thing happened in the abdomen with the peritoneum. Okay, so now let's just go ahead and use this blue again. The blue is going to go by the visceral peritoneum. Okay, so the blue is visceral peritoneum. Look at that. Okay, it's covering the liver right there. Okay, and then after that, at the abdominal wall, this layer is going to fold on itself to become the parietal peritoneum. And the space in between them, this space here, is the peritoneal cavity. All right. Obviously, I'm not doing this for every single organ, but you have the idea. You got the idea. Okay. It's just that it's not the parietal and the visceral peritoneum. They are not two separate structures. They are one and the same structure, only folded back on itself. All right. Okay. So now the abdominal viscera can be divided into whether they are mostly covered by peritoneum, also called peritoneal organ, or only covered in part by peritoneum. You call it retroperitoneum. Okay, so the intraperitoneal organs and structure are suspended from the abdominal wall by mesenteries, while the retroperitoneal organs and structures are not suspended in the abdominal cavity by a mesentery and lie in between the parietal peritoneum and the abdominal wall. All right, so now let's just go back to this picture and find out something. You see, in this image, okay, you see the stomach right here. Sorry about that, it's hard to see. Okay, the stomach right here is completely almost covered by visceral peritoneum. Okay, and it is hung by these ommenta and mesenteries. All right, and so therefore, a stomach is an example of an intraperitoneal organ. Same thing goes with these loops of the small intestine. They are all intraperitoneal. But then, when you talk about these organs, like for example, the aorta, the vena cava, okay, the inferior vena cava, then you see that peritoneum only covers the anterior aspect of these organs. Okay, so these things are retroperitoneal. All right, same thing with the duodenum right here, retroperitoneal. The pancreas right here, retroperitoneal. Okay, and when you get to the lower point of the peritoneal cavity, something very interesting happens. These organs, the rectum, okay, as well as the urinary bladder and the uterus in the female, okay, they are all going to be covered by peritoneum, but only on their superior aspects. And because of that, what they are called is they are also retroperitoneal, but they also have a name that is subperitoneal. Okay, they are subperitoneal. They are under the peritoneum, if you will. All right, and therefore you got structures that are intraperitoneal. You got structures that are retroperitoneal. All right, and so the retroperitoneal organs can actually have a mnemonic so that you can remember them all, and it is Sad-Pucker. So Sad-Pucker, S is suprarenal or adrenal gland, and with that, you can always know that, okay, so if suprarenal is retroperitoneal, the kidneys will have to be retroperitoneal as well, hence the K. Then you have the aorta, and if you know the aorta, you know that the thing that's running right to the right of it, the IVC, is also going to have to be retroperitoneal. Then you have the duodenum. The duodenum is kind of an interesting structure because the duodenum has 4 parts. Okay, but only the second, third, and fourth part are retroperitoneal. The first one is actually intraperitoneal. All right, so that's very interesting there. And the pancreas is also going to be retroperitoneal, except for the tail. The tail will extend into the splenic hilum, and therefore, because the spleen is intraperitoneal, the tail of the pancreas will have to also be intraperitoneal. All right, now the ureter, the ureter is also retroperitoneal because the kidneys are retroperitoneal. Okay, now the colon is an interesting case because it says colon here, but not every part of the colon is going to be retroperitoneal. There are only 2 parts of the colon that are retroperitoneal, and those parts are the ascending colon and the descending colon. Okay, so AC and DC, those are going to be retroperitoneal part of the colon. Then you have the esophagus, okay, or the distal part of the esophagus, the one that travels through the diaphragm to get into the abdominal cavity. That part is retroperitoneal, as well as the rectum is also retroperitoneal. Sad pucker. All right, so now retroperitoneal organs are further divided into primarily retroperitoneal and secondarily retroperitoneal. Now, you don't really have to know right now which one is which, but you do have to know what the definition is. For organs that are primarily retroperitoneal, they actually develop retroperitoneally. So they develop in the region between the abdominal wall and the peritoneum and just remains in this position in the adult. Okay, so they develop retroperitoneal, so they are retroperitoneal through and through. Okay, and some examples include the kidneys, the ureters, the IVC, and the aorta. All right, now the structures that are secondarily retroperitoneal are suspended initially in the abdominal cavity by a mesentery. So basically, they used to be intraperitoneal, but then they becomes retroperitoneal by fusing with the abdominal wall. And for example, we have the parts of the duodenum, the pancreas, the ascending and descending colon. They are all organs that are secondarily retroperitoneal. All right. Okay, so innervation of the peritoneum in terms of nervous innervation, what we really want to get to with the peritoneum is going to be the sensory innervation. Okay, so we have a little bit of a difference in terms of parietal peritoneum and the visceral peritoneum in terms of afferent or sensory innervation. Okay, in terms of parietal peritoneum, you have the somatic afferent nerves that carried in branches of the associated spinal nerves of the abdominal wall. So the parietal peritoneum, okay, in short, it is very sensitive to well-localized pain, which means if you are hurt here, for example, in the parietal peritoneum, you will know that you are hurt exactly here on the parietal peritoneum. But for the visceral peritoneum, they are the visceral afferents neurons that accompany automatic nerves, okay, autonomic nerves, the parasympathetic or sympathetic nerves back to the CNS, okay? And therefore, the thing that you have to know about that is for the visceral peritoneum, you can be hurt like, here on the surface of the stomach, and you would feel like you are hurting at the entire epigastric region, all right? So it's poorly localized. It cannot be known as a point of pain like in the parietal peritoneum, but it's actually a region of pain, okay? A region of pain. Now, what is the clinical correlation of that? The clinical correlation of that is appendicitis, the pain due to appendicitis. Now, for appendicitis, in 50% of patients, an inflammation of the appendix will present first with a central periumbilical pain. Why is that? Simply because of the fact that the appendix belongs to the midgut. Remember, everything from the distal part of the duodenum all the way to the first half of the transverse colon, that's going to be midgut. And therefore, you have the appendix right here being midgut. And the midgut is going to refer back so that we feel pain right here on the periumbilical region. All right. And therefore, because when you're first hurt here, okay, when you're first in pain from a pain here, that pain is poorly localized because it's still in the visceral peritoneum. And then what happens after a couple hours? The appendix becomes so inflamed that it got in contact with the parietal peritoneum usually at around like, McBurney's point or like, the abdominal wall on the right inguinal region. And therefore, you can feel the pain right there, okay, on the right inguinal region. And you can point to a point where you feel pain because now it is already getting into contact with the parietal peritoneum. And now you can feel localized pain. All right, very important stuff. All right, so now the peritoneal cavity. The peritoneal cavity is further divided into the greater sac and the lesser sac. Okay, so now in this picture, you can see that the greater sac is here in dark brown, okay, and the lesser sac is up here, okay, in a lighter shade of brown, okay. The lesser sac is this portion, okay, is this portion that lies posterior to the stomach. The stomach's right here, so it's like posterior to the stomach and the liver, okay, posterior to the liver as well, and continuous with a greater sac through an opening, aka the omental or epiploic foramen of Winslow. We will get to that once we examine the lesser omentum. Now, the greater sac is this huge sac in the anterior side right here and extending all the way down here to the pelvic region. And it is actually account for most of the space in the peritoneal cavity. All right. It is entered when the parietal peritoneum has been penetrated. Like, for example, when you cut open the abdomen, the first thing that you will encounter will be the greater sac. All right. So now, let us go on and talk about this for a second. Now, you see, this is the stomach, right? This is the stomach. This is the liver, and the liver here has been lifted up a little bit, okay, to the right side, so that you can see this membrane that runs in between the stomach, as well as the first part of the duodenum, over to the liver, that one there. That one is collectively known as the lesser omentum, okay, but it's also divided into two, the hepatoduodenal ligament coming from the duodenum to the liver, and the hepatogastric ligament coming from the stomach to the liver. Now, right here at the free edge, okay, of the hepatoduodenal ligament, you can actually insert a finger, okay, can insert a finger right there, and that finger will go into the space posterior to the stomach and the liver. Now, that space that your finger has entered is the lesser sac, also known as the omental bursa. Okay, so the omental bursa is going to be this space right there. You see that? That is going to be separated from the rest of the peritoneal cavity, or also called the greater sac, by this foramen of Winslow right here that your finger can actually access. Okay, now this is a very important, guys. You need to know which one is the greater sac and which one is the lesser sac, okay, as well as how to access the lesser sac, or also called the omental foramen. The omental bursa. All right, cool. All right, so now let's go on and talk about the omenta, the mesenteries, and the ligaments of the peritoneum. Now, those are peritoneal folds that connects organs to each other or to the abdominal walls, and they develop from the original dorsal and ventral mesenteries. Now, some of them will contain vessels and nerves to the viscera. Others will help maintain the proper positioning of the viscera. So now, let's just go on and talk about the two omenta. Okay, the two omenta includes one greater omentum that looks like an apron, okay, that extends from the stomach, the greater curvature of the stomach, hence greater omentum, and travels down and loops back up to eventually inserts into the transverse mesocolon. You will not be able to see it here, but you will in the next image. Now, for the lesser omentum, it is this structure that you can see peeking out right here, okay? And it comes from the lesser curvature of the stomach, hence lesser omentum. And it extends from that all the way to the liver, okay? And there will be also another part of the lesser omentum that extends from the proximal part of the duodenum to the liver as well, okay? Now, the greater omentum has 4 layers, okay? And it attaches first to the greater curvature of the stomach right here, and then it also attached to the first part of the duodenum, a very small part, and it's going to go down, loops back up on itself, and it inserts to the transverse mesocolon. All right. Now, it attached to the transverse colon. I'm sorry. It drapes over the transverse colon and the coils of the jejunum and ileum, and then turns posteriorly and ascends. And eventually, it becomes associated with and adherent to the peritoneum on the superior surface of the transverse colon and the anterior layer of the transverse mesocolon before arriving at the posterior abdominal wall. Now, even though it is a 4-layer peritoneal fold, it is actually usually a thin membrane, but always contains an accumulation of fat, okay? A lot of your visceral fat is from the greater omentum, all right? Now, the right and the left gastro-omental vessels will run in between the 2 layers of the greater omentum, just inferior to the greater curvature of the stomach. Now, let's look at it more on the sagittal cut. So in the sagittal cut, you can see the reason why the greater omentum has 4 layers, okay? So you got 1 layer and 2 layers of the visceral peritoneum that covers the stomach go down here, okay, and becomes the first part of the greater omentum. And it's going to travel down here. It drapes over some of the coils here of the small intestine, and then those 2 layers right here and right here is going to loop back up on itself like that. So as of right here, how many layers does it have, the greater omentum? 4 layers, okay? So you got 2 layers in front, 2 layers in the back, so 4 layers, okay? The 2 layers in the back will continue to go to the transverse colon. It drapes over the transverse colon right here until it becomes the transverse mesocolon, okay? Transverse mesocolon, TMC. All right, so it basically drapes over the transverse colon, becomes the transverse mesocolon, and then it goes and attaches itself back into the parietal peritoneum of the posterior side of the abdominal cavity. Okay, so that's how you know that there's 4 layers of this omenta. All right. Okay, so a clinical correlate, an important one for the greater omentum, is basically, it is called the policeman of the abdomen. Why? Because of its ability to migrate to any inflamed area and wrap itself around the organ as to wall off the inflammation. Now, let's suppose that your appendix is inflamed, right? So the greater omentum can actually move, okay, to the appendix and wall off the appendix, okay? And that becomes one of the signs that is quite important in ultrasonography as well as in radiology in general. The fat infiltration sign. Okay, when you see that, like, you know, an organ in the abdomen is surrounded by fat on a CT or on ultrasound, there is a good chance that that organ has actually been inflamed, and the greater omentum, which contains fat, is going to go over there and kind of drapes over the organ so as to protect the organ and to wall off the inflammation, preventing it from spreading elsewhere. All right, so this process is actually quite complicated, but you can read more here to find out, okay? But remember this, guys, the greater omentum is usually called the policeman of the abdomen because of its ability to surround an inflamed organ and to wall off that organ from further spreading the inflammation elsewhere. All right? All right, so now let's talk about the lesser omentum. The lesser omentum is this membrane right here, this membrane that has 2 parts. Part 1 is going to extend from the lesser curvature, hence lesser omentum, to the liver. That is called the hepatogastric ligament. And then there's another part right here, okay, extending from the proximal part of the duodenum all the way to the liver. You call that the hepatoduodenal ligament. So the lesser omentum is the hepatoduodenal ligament plus the hepatogastric ligament. All right, so that's lesser omentum. Now, it ends laterally here as a free margin. And in that free margin, vessels are going to course within it, okay? Now, you have the hepatic artery proper, the bile duct coming from up here, as well as the portal vein that are going to, that's going to be running within, like, you know, this free edge over here, okay, of the lesser omentum. So imagine all of those vascular components running within here, like that. All right. Now, the right and left gastric vessels, right gastric vessel here and the left gastric vessel here, they are in between the layers of the lesser omentum, and they are near the lesser curvature of the stomach. All right. So they are here and they are here. And that is very important, especially when you have to find the vasculature of the stomach in surgeries. All right. Very important. Mesenteries. So mesenteries are peritoneal folds that attach viscera to the posterior abdominal wall. They are derivatives of the dorsal mesentery, and there are a lot of them. Okay, they allow some movement of these organs and provide a conduit for vessel, nerves, and lymphatics to reach the viscera. And they include the mesentery, which is associated with the majority of the small intestine. The majority of the small intestine, excluding the duodenum, which is primarily retroperitoneal, is going to be hung from the posterior body wall by this mesentery called the mesentery. All right. So now, besides from the mesentery, you also have the transverse mesocolon that is associated with transverse colon, as well as the sigmoid mesocolon that is associated with the sigmoid colon. So now let's go on to look at every one of these guys in a little bit more detail. All right, so the mesentery is this membrane right here. You see that? That membrane right there? Okay, and it is going to suspend the majority of the small intestine to the posterior abdominal wall. Okay, there is something right here. This is a structure where the mesentery is going to originate from, and we call that the root of the mesentery. And the superior attachment of that mesentery root is the duodenal-jejunal junction. You see that? The duodenum is right here, jejunum is this portion right there, and the root of the mesentery actually starts superiorly right here. Okay, it's going to go down and down and down obliquely and to the right and down and to the right until it gets here where it ends. Okay, at the iliocecal junction in between the ilium and the cecum. Okay, so where's the root of the mesentery? First off, it starts here at the duodenal-jejunal junction, going to go down and to the right and down and to the right until you get here to the iliocecal junction. All right, now the arteries, veins, nerves, and lymphatics that are supplying the jejunum and ilium will travel within the two layers of this structure. Like, for example, you see all of these jejunal and ilio arteries right here. They will have to course within the mesentery itself in order to get into these organs. And it makes sense too, right? Because if you think about it, the aorta is a retroperitoneal structure, and so is the IVC, and so is the portal vein. Okay, and therefore, if you want to have branches from a structure that is retroperitoneal in order to get to a structure that is intraperitoneal, how would you do it? You have to use the mesenteries, right? Because the mesentery is going to extend all the way from the retroperitoneal region all the way here and attach to the coils of the small intestine, which are intraperitoneal. Okay, and so you have to travel within the layers of the mesentery. That's a rule. Okay, think about this more and you find it makes sense. Okay, so one more look into the root of the mesentery. Okay, it extends all the way from here, the duodenal-jejunal junction, all the way down here, iliocecal junction. All right, so now let's talk about transverse mesocolon. Transverse mesocolon is this mesocolon that suspends the transverse colon to the posterior abdominal wall. All right, and of course, there will be arteries, veins, nerves, and lymphatics that are related to the transverse colon will have to travel via this transverse mesocolon so that we can get to the transverse colon. All right. Now, this is the root to the transverse mesocolon right here, okay? It's on the abdominal, it's on the posterior abdominal wall, okay? And now we'll look at the sigmoid mesocolon. The sigmoid mesocolon is going to be this mesocolon right here, all right? That is going to be connecting this part, aka the sigmoid colon, okay, this part, into the posterior abdominal wall. The root of the sigmoid mesocolon is here, and as you can see, it has an inverted V shape, okay? It looks like a mountain, okay, an inverted V. Now, the left limb, which is basically this limb right here, this part right here, of the descending V is going to be along the medial border of the left psoas muscle. So the left psoas muscle is going to extend like that. It's going to go down like that, right? Iliopsoas is right here. So it's going to extend over here, over the left psoas muscle. Okay, and now the right limb, which is this limb right here, okay, of the V is going to descend into the pelvis to end at the level of the S3 vertebra, okay, around here somewhere, okay? And that is going to be the root of the sigmoid mesocolon. And of course, there will be nerves, lymphatics, and veins that comes from the posterior part into the sigmoid mesocolon so that it can get to the sigmoid colon. All right. All right, so now let's talk about some ligaments. Now, peritoneal ligaments are two layers of the peritoneum that connect two organs to each other or attach an organ to the body wall and may form part of an omentum. And they're often named after the structure being connected. Like, for example, you have two ligaments here, the splenorenal ligament and the gastrosplenic ligament. So now, splenorenal, what does that mean? Spleen and kidney. So this ligament here is going to connect the spleen and the kidney. Now let's see. The spleen is here. The left kidney is here. What is the thing that connects them? This one. Okay, this structure right there. So that structure right there is going to be the splenorenal ligament. Make sense? And now, where do you find the gastrosplenic ligament? In between the stomach and the spleen, exactly. So it's this one, okay? Gastrosplenic ligament. So those are two examples of ligaments. Okay, the pelvic peritoneum is kind of weird, okay? Because as we have already said before, when the peritoneum extends down here, it's going to drape over, okay? It's going to drape over the structures of the pelvic cavity, but it only drapes the superior part of these structures. And therefore, these structures like the urinary bladder, the uterus in the female, as well as a lot of the rectum, they're going to be called subperitoneal organs. And in the course of doing all of the draping on the superior part of these organs, the peritoneum actually formed pouches between adjacent viscera as well as folds and ligaments between viscera and pelvic walls. All right. And also, please do not forget about these folds, okay? These folds on the posterior wall of the anterior abdominal wall are very, very important. Let's go over them just once so that we understand what they are. We go first to this fold here, also called the lateral umbilical ligament, this one here. The lateral umbilical ligament is going to be the peritoneal fold that is going to drape over the inferior epigastric artery and vein. All right. So if anybody ever asks you, what structures are under the lateral umbilical ligament, you say inferior epigastric artery and vein. All right. So now let us go to the medial umbilical ligament. The medial umbilical ligament is going to cover the embryological remnant of the umbilical arteries. All right. The umbilical arteries in the embryo is going to be non-functional in the adult, and therefore there will be a drape of peritoneum that is covering the remnant of those structures, and that is the medial umbilical ligament. And the median umbilical ligament is the thing that is going to cover what is known as the urethus. Okay, the urethus in the embryo. All right. Now, in the women, the uterus is going to lie in between the bladder and rectum. We have already learned about that in reproductive anatomy. All right. So we will see that there are going to be two pouches. This pouch in the front is going to be called the vesical uterine pouch because it's in between the bladder, vesicle, and the uterus, uterine. All right. So vesical uterine pouch. Now, this second pouch here, that is going to be the deeper pouch, is going to be called the rectal uterine pouch between the rectum and the uterus. And this pouch is also called the pouch of Douglas or the female cul-de-sac. Okay, let me just type that out here. Cul-de-sac. Okay, so the female cul-de-sac is also called the pouch ductless or the rectal uterine pouch. And it is very important because in the clinical setting, fluid usually accumulates there if it is in the peritoneal cavity as well. Remember when we talk about the liver that we said something about the Morrison's pouch, okay, the Morrison's pouch being one of the fluid accumulating place within the peritoneal cavity. Well, now you have another place where fluid can accumulate, okay, the rectal uterine pouch or the pouch abductus. All right, and it's in between the rectum posteriorly and the uterus anteriorly. All right, very, very important. So now, in some cases, if you see fluid in the rectal uterine pouch, you would want to aspirate some of that fluid, right? You would want it to get some of that fluid out in order to do some kind of test with it. So how can you do it? How can you actually get a needle into the space in order to get the fluid out? Well, if you remember it, you will remember that the vagina up here forms a fornix, right? The vaginal fornix. And the vaginal fornix is going to be divided into the anterior, posterior fornixes, as well as the two side fornixes, right? Now, let's see. What is that? Posterior fornix, okay? So the posterior fornix, notice how it's so close to the rectal uterine pouch. There's only one thing that separates them, and it's this wall here. So now, if you get a needle, you go into the posterior fornix, you can actually go through this wall, get into the rectal uterine pouch, aspirate the fluid, and go out. Okay, and that is what people know as the procedure of chodocentesis. Chodocentesis, cul-de-sac, right? And it's very, very similar to each other. All right, so that would be in the female. Now it's going to be in the male. The male cul-de-sac is also called the rectal vesicle pouch, and it's going to be in between the rectum and the urinary bladder. That's it. Okay, in the male, it's much simpler than in the female. All right, so now we have gotten to the development of the abdominal viscera. And like I said, we are not going to go through this because you are going to learn about them in the embryology class anyway. But we are going to go through the very, very basics. Okay, so the primitive gut, just like we said before, is going to compose of three parts: the foregut, the midgut, and the hindgut. The foregut is going to be supplied by the celiac trunk, the midgut, the superior mesenteric artery, and the hindgut, the inferior mesenteric artery. So the foregut organs are going to be, you got the stomach, the spleen, the pancreas, okay, the duodenum all the way up to its descending part, okay, and the liver and gallbladder, as well as the biliary tree. Those are going to be foregut organs. Midgut organs extend all the way from the last part of the duodenum to the first half of the transverse colon. That's midgut. And hindgut is everything else until you reach the inferior part of the rectum and anus. That would be the hindgut. Okay, so now the massive longitudinal growth of the gut tube and rotations of the selected part of the tube and secondary fusions of some viscera and their associated mesenteries to the body wall will participate in generating the adult arrangement of the abdominal organ. Now let's talk about the rotations of these tubes. All right, so now there are an important turn. Okay, there are some important turns that happens at a foregut, midgut, and hindgut. For the foregut organs are going to rotate 90 degrees clockwise around the central axis through the stomach. All right, so within the embryo, the organs of the foregut first are going to be like this. At the front, you have the liver. Okay, that's the liver. In the middle, you have the stomach. And right here, you have the spleen at the back. Okay, but then after this rotation, okay? The rotation is 90 degrees clockwise, and therefore you rotate like that, all right? And after you rotate like that, the liver is here. This is going to be right, and this is going to be left, by the way, sorry. And then you have the stomach here, and then the spleen here. And that is why in the adult, the liver is going to be the one that's on the right side. The stomach is going to be the one that's on the middle, and the spleen is on the left side. Okay, that's foregut rotation. And that also explains why, okay, up in the thoracic cavity. And that also explains why up in the thoracic cavity, you have two vagus nerves, one on the right and one on the left, okay? But then when you get to the abdomen, the left vagus nerve becomes an anterior vagal trunk, and the right vagus nerve becomes the posterior vagal trunk. Why? Because there has been this rotation that took place. So everything on the right side becomes more, everything on the right side will become more posterior, and everything on the left side will become more anterior, okay? That makes sense now, right? So before, you don't know, now you do. All right, so now the midgut rotates 270 degrees counterclockwise around the superior mesenteric artery. So the axis of rotation is not an organ, but it's actually a vessel, the superior mesenteric artery. And because of this, the organs of the midgut, especially the coils of the small intestine, is going to settle into its place within the peritoneal cavity. And then finally, the proximal part of the hindgut will swing to the left and become the descending colon and sigmoid colon. And those are the main points of the development of the abdominal viscera that you need to know. All right, and that is it. Thank you very, very much for getting with me so far. It has been quite a difficult lecture, I know that. So please make sure that you get back home and review it very, very carefully, especially which organs are intraperitoneal, which organs are retroperitoneal, because that is going to be very important in your education going forward. My name is Kwa, lecturer of anatomy, physiology, and medical terminology. Thank you and goodbye.